Okay, here we are. Hello, everybody. My name is Ellie Wilson. I'm a registered dietitian, and I am here today to support and help us discuss food as medicine. We have a terrific panel that are going to share a little bit about each of their programs, and we'll all get to see a little bit about what makes these models so important to our community food security and moving health forward in our communities. What we'd like to do a little bit here is to set the table, if you will, and we're going to be able to offer a slide here that gives us a definition of what is food as medicine. Let's go. Oh, technical fun. Sorry, all, we're on the wrong slide. What we're going to be sharing and what is in your materials is the definition that has recently been developed by the Academy of Nutrition and Dietetics of exactly what is food as medicine. I apologize, I don't have control here, Libby. It is not going back to the other slide. So we'll just stop that screen at the moment. And the three pillars of this food as medicine is really that food should be part of how we support optimal health and prevent chronic illness, that there is an opportunity to drive benefit through food access and reducing food insecurity, and that also that food is part of how we manage chronic health conditions and optimize health no matter where a person is starting, that we can move people forward from any starting point with improved access to the appropriate qualified nutrition care and food to help bring that solution really together for an individual and for a community. You can again see that those resources are uh, in the materials for today, and I'm going to try to share again because this should be showing us the screen. Right now it's telling me it's canceled. Okay, we'll just leave it there for now. Um, what I'd like to do is introduce our panelists and then have them share a little bit about each of their models, and then we're going to go into the questions that we have set up for the program. So the first is Alex Alamadine. She's an RDN. She is the Food Pantries of the Capital District Special Initiatives Manager. We have Josh Stefani from Comfort Food Community, which is in Washington County, and he is the Community Health Coordinator. Washington County is a north country above the Capital District county, quite rural. We have Kathleen Emmett, kind of a completely opposite region from she's the the manager of community nutrition programs at Island Harvest Food Bank in Long Island. So a lot more densely populated, a lot more urban. And then Hannah Shahade, who is an RDN with Catholic Charities Food Pharmacy Program. With that in particular focuses on medically tailored meals. So welcome everyone. Alex, why don't we start with you? And would you please share, what are some of the primary features of the programs that you work on that support food as medicine in the Capital Region?
Yeah, thank you, Ellie. So our program at the Food Pantries for the Capital District works with a coalition of 17 food pantries within our 65 plus pantry coalition. We serve throughout the 4 counties of the Capital Region, so Albany, Rensselaer, Schenectady, and Saratoga. And we're really looking at that population of about 10% of the population that is food insecure. Our model addresses 3 different targets, and that is our monthly food as medicine model. So that really targets aim of quality of food. We have a medically tailored model, which is a weekly package of food, which really looks at the health outcomes. And then we have a prepared meal model, which is really focusing on getting quick access, prepared meals, primarily to those coming right out of the hospital. And so this is a initiative that focuses on advancing health equity within our healthcare system. So we're working with our local community providers, so our our food pantries. We're working with community organizations, local community organizations, as well as our healthcare networks and insurance companies.
Terrific. Thank you very much. Josh, can you share the Comfort Food Community resources?
Yeah, thank you. And thank you, Ellie, for that introduction as well. So Comfort Food Community, like you said, is in Washington County. And just for context, we're talking about county, both Washington and Warren County are about 20% food insecure, and about 25% of the population has reported eating the minimum standard of 5 servings of fruits and vegetables on a daily basis. About 20% admit to eating only less than 1 serving in the area. So what we're really trying to do is flip not only that emergency food system model on its head. We operate a few pantries, one based in Greenwich and also Cosuna to the north, but also looking at distribution. And I like to say we don't just have one food as medicine model. Food as medicine touches across all of our programs. Specifically within the community health realm, we work with Hudson Headwaters as a healthcare provider to provide a clinically tailored CSA share, if you will, really focused on patients through their services who have identified chronic illnesses. This most current round, we're focusing on individuals with diabetes, and we're in our 3rd round currently. Our first round actually saw more than 50% of the individuals saw a significant, at least 2-point decrease in their A1C levels, which is amazing. And also we work with CDPHP as a payer for health insurance to incentivize and encourage individuals to shop at farmers markets and purchase fresh fruits and vegetables through a produce prescription program in Glens Falls as well. All of our different models really touch upon this idea of food as insecurity as not solely about providing food. We focus on education, whether it be health information or culinary information, but also thinking about the food that we distribute as medicine in itself, right? So I like to say it's one thing to give someone a butternut squash, but if you have arthritis and have limited dexterity in your hands, how are you going to prepare and cut that butternut squash? So a lot of our clientele are very rural. They're also very they struggle with transportation. So, and a lot of our individuals are part of our senior population. So we're really working to flip that model and how we can really serve that larger population and really focus on food as medicine and not just providing your traditional non-perishables that a food pantry would.
Excellent. Kathleen, would you please share the Island Food Harvest Community Nutrition Program model?
So Island Harvest Food Bank, we're here on Long Island. We cover Nassau and Suffolk County on Long Island, and not unlike Josh's program, we have our Food is Health model cuts across a lot of different programs. And we've had a nutritionist on staff here at Island Harvest for over 15 years, and I would say that we started out doing just a lot of nutrition education, cooking demonstrations, and always looking for ways to make bigger impact. Worked with our in-house operations team to try and procure healthier foods, work with donors to try and get them to donate healthy foods, and continue to do that. And so we have a very strong nutrition education component, and like Josh as well, we are very much focused on not just education about nutrition, but about information about the foods that we provide and the best way to utilize them. About 3 years ago, we partnered with Northwell Health Care here on Long Island, and we established our food pharmacy within a hospital setting. And that was a very simple program. The hospital would screen for food insecurity, and clients who would food insecure who were managing chronic health conditions, 5 chronic health conditions were identified, such as diabetes, hypertension, COPD, CHF, were referred to our program. We staffed the program. We established a healthy food pantry in the hospital, and we staffed the program with a registered dietitian nutritionist who would meet with clients. And clients were only allowed to meet 3 times with a nutritionist. And we felt like we made some impact, but we thought that we could make a bigger impact if we could have more time with the clients, and as well if we could be more embedded in the communities that they're in, because the 2 hospitals that we were at were somewhat removed from some of the communities that we were seeing the most food insecurity in. So about 2 years ago, we reached out to first we started with behavioral health centers, and currently we're in federally qualified health clinics in Nassau and Suffolk County. We established a partnership with them in which we come in with a registered dietitian. We establish a healthy food pantry. The dietitian actually orders the food, based on, health needs and cultural preferences, and meets with clients. The health centers screen the clients for food insecurity and refer them to us. And as a part of this program and meeting with the nutritionists and talking about their food and nutrition needs, and we started to go beyond just food and nutrition, obviously, to address other social determinants. So as a part of their intake with the dietitian, they're always asked about whether or not they're enrolled in SNAP, and asked if they'd like assistance with SNAP. And then we referred to an in-house person at Island Harvest to walk them through the SNAP process, to get them connected with WIC, or to address other needs beyond just food. So we're trying to make it more holistic, and we're trying to set up a situation in which after they're finished meeting with us and getting the healthy food that we provide, they can step off from our program and continue with some of the learnings, but as well be able to access healthy food. I mean, there are things that we've learned that coming into it we would never thought of. Many of the people that we meet with are recent immigrants, and they know about whole foods, and they know about the importance of food as it relates to health, because in their country, most of the food they were eating before they came here was whole foods. So now that they're here and they have access to foods that are not so healthy, we have to kind of re-educate. And as well, we have to work with them, because a barrier or a resource that they do not have much of, many of the people that we meet with, is time. And so we've found ourselves working at addressing the issue of time, the issue of limited kitchen facilities, more than good nutrition with a lot of people. Talking to somebody who is working several jobs and has a family and maybe is a single parent, and telling them that, okay, now you're going to go out shop, you're going to cook and prepare this food, is beyond challenging for some people. So we do spend a lot of our time thinking of creative ways to help them do this quickly and but still be healthy.
Sure.
So
So that
that's a
sounds
snapshot.
like, really, it's a combination of the fact that you really have to understand the people you're serving, so that you really can tailor, which is a word that you've all used in one way or another, or a synonym of, is that these are tailored interventions that are really, really designed to be, for lack of another term, super effective for that person, and carry them forward and out of the system. So Hannah, would you please share some of the work that you do with Catholic Charities?
Sure. Hi, everyone. Hope you're doing well today. I know we're right before lunch, so if you could just hold on a little more. It's nice to be with you guys today, though. So my name is Hannah, like Ellie said, and I'm a dietitian, and I work for Catholic Charities Tri-County Services. So we're in the Capital Region in New York, and we actually have 2 food pharmacy programs. One of them is in Schenectady County, and the other is in Albany County, so still in the Capital Region. and I had the pleasure of being able to help open both of these programs and work at both of these programs. So in just a short under 3 years so far. They are very similar. The food pharmacy model is that similar to kind of what Kathy was saying is an individual gets screened for both food insecurity and maybe some sort of nutritional risk that they might have, whether that is they have a chronic illness or they are at risk for developing a chronic disease. They get referred to us. And right now we have 4 nutrition education sessions with a dietitian and 4 food packages that, before the pandemic, we were able to have clients come in and choose 100% what they wanted to eat from our healthy food pantry. And now it's still client choice, but it ends up being a food package that they either pick up or we deliver. And we have so the Ellis one in Schenectady, just last year, we served over 550 individuals. And of course, that is from, different households, household of 1, 2, maybe even 10 people in a household. So yes, we serve the whole household as well with these fresh and healthy foods and resources. And then in Albany, we've been operating for almost a year. And we have served about 780 individuals in just that year so far. And we are connected actually as well to the program that Alex was speaking about with the food pantries. So we're kind of running a food pharmacy as well as weekly packages to clients for 6 months. So we kind of see the benefits of both of these programs and being able to use ideas from both of these programs to help serve our clients in the best of ways. And so, like I said, we have a dietitian on staff for each of these food pharmacies and a food navigator. For example, the food navigator at our food pharmacy now in Albany has a lot of case management experience. So she is able to help with resource navigation and help to address more of those social determinants of health. So things other than nutrition, like Josh was mentioning, we need to get the right equipment and we need to make sure that our clients can cut a butternut squash or can use and prepare the food that we give them. And, we do have a difficult time getting data. It's very hard in an area like this to get numerical data. However, we have had plenty of clients, which I'll share later, some success stories with improved mood, increased energy, and really just an improved quality of life, which I think all of us here can agree that's exactly what we're looking for. So
Absolutely. That is a really great end point when you think of the fact that healthcare and value-based care and all of these changes in healthcare, part of the triple aim is quality of life and improved individual consumer patient experience, right? So all of these things really do lift people into that ability. Let's even just think about the term food as medicine. It is something that has to be acknowledged that nutrition and qualified nutrition care has not been easily available in our healthcare system. And there are definitely changes coming, but we literally had to lift food into a medical application. And I hope that what we do is really do drive the capacity to keep developing these holistic models. Okay, so we have some questions that we are going to cover as a group, and we also have some opportunities we'd like to share, some aha moments. I mean, Kathleen, I think you already did that with just outlining, what you discovered about the immigrant population that you served, that they weren't necessarily unfamiliar with food or preparation. It was their real challenge was time. And so understanding that and how do you bring healthy food into that particular need in a new environment is a really key way to help people do better in their new community. So the first question we have is, can you explain how your food is medicine model works, how you meet your community needs? I think we actually just did that. So let's go to really, what is the purpose of the program? If you guys can just target that or narrow that down, what is your primary outcome that you are working to serve? Alex, would you start, please?
Yeah, sure. So most of us know, and if you don't know, as food insecurity worsens, health, disease, and obesity worsens. It's, correlated, it's connected. And so big picture in simple terms, like we would really like to just create healthier people, but how do we do this, right? Where do we see this program going? I mentioned a little bit earlier, we have 3 different service levels, and each service level tries to aim at something different because we are trying to adapt and meet the needs of our community. That Healthy Food Pantry monthly service provides about 10 ingredients and food for about 10 meals. So it is a supplemental package that the client receives monthly. And the purpose of that program is to improve your quality of food. So access to high quality items, integrating some of those into your diet a little bit more. Our medically tailored food service level really is looking to aim at improved quality health. So the medically tailored service level is working with clients that are not only food insecure, but also have an underlying health condition. And so the weekly packages that they're getting contains food to make 10 meals a week. So it is a larger quantity of food. And it's tailored to their specific health condition. So, whether it's diabetes or hypertension or obesity, the meal or the food will reflect that diet, focusing on low sodium items or low sugar items, so that we can affect health outcome. The third service level is the prepared meals. And that's really the aim, like I said before, is to get access to prepared meals. We are dealing with clients that are coming out of the hospital. And so oftentimes, they might not have transportation to go to the grocery store, or they might not be able to cook food themselves because they are recovering from their visit in the hospital. And so we just want them to have access to high quality food. And this service level, they get food every single day for a 2-week span. We oftentimes see a client that was referred to our prepared meals be referred into one of our other service levels afterwards. So they might get referred to a monthly package or a weekly package. And long term, going off of what Hannah said, is really looking at those numbers. We know that Medicaid currently offers medical nutrition therapy for some of the Medicaid clients as a reimbursable cost, but the access to quality, fresh fruits and vegetables and healthier items is not necessarily supported in that. The education component is supported in that, and how to make those healthier choices is supported, but the access isn't. So long term, we would really like to be able to show the health outcome data, show the food insecurity data, saying that, by having access to these programs, not only decreases food insecurity, but also increases health outcomes, creates healthier individuals. Then we can go to the state and we can say, hey, would you like to reimburse for Medicaid? There's a crazy number that states to fund diabetes in the United States, it is a budget of $160 billion to treat diabetes. And the entire budget of the USDA is only $150 billion. So it's less than what it costs to treat diabetes. And so if we can think about reimbursing for Medicaid, reimbursing some of these programs to get access to quality nutrition food to our clients and to our participants, that is a way to redirect some of those funds and put them towards prevention rather than reaction. Oh, Ellie, you're muted.
Would you, oh, sorry. Josh, can you please, I'm betting that we're going to echo each other here when it comes to what are the targets, but if you wouldn't mind.
Yeah, and I think Alex said it best. I think the big goal is to create healthy communities and healthy beings, which is a lofty goal, and I think we're all doing some component of it. And the only thing I would like to highlight, we have a few different models within food as medicine here, and the one aspect, and I know Alex, you mentioned it, so I'm going to echo it as well, is that integration of healthy, nutritious, but also that access to fresh food. And if you look at our pantry models, yes, you can get the non-perishable supplemental, but we really pride ourselves on making sure that local, available, fresh food from farms within a 30-mile radius, 30 to 50-mile radius, are making it to our pantry and making it to our guests. So something that is very, for those who have low resources or lower income and struggle to use their SNAP benefits at the grocery store, this is an option of being able to provide unlimited produce to their families and themselves. And our pharmacy program as well is a clinically tailored model. So it's very similar to Alex's and Hannah's models, where we actually work with individuals direct from a clinical setting coming from Hudson Headwaters. They're individuals who are identified as high need, low resources, that have a variety of comorbidities and chronic illnesses. So we're working directly with that. And to echo Hannah as well, one of our biggest goals is that data component. It's always difficult to get the data, but the behavioral change, that willingness for people to just try new things, or substitute, or even add an additional, adding that apple to a school lunch, or an orange, or something like that. Or, I always cite my father, just adding that piece of lettuce to his hamburger, or something like that. Just getting that extra step. But one of our biggest difficulties, and is really, especially in the North region, and as we get into the Adirondacks, is linking the connections where this fresh food is available. Transportation remains a significant barrier in this area. A lot of our communities, the source of food is a Dollar General, or some even a Stewart's or something like that. And so one way we're trying to broaden our food as medicine model is to help lead the effort on the food system around the Adirondack region as well. So there are so many different models on how we can fit food as medicine in that, but it all comes down to these larger goals of how can we improve individuals' ability to access that food, and also can we bring that food to places that they're already going, such as doctor's office? Can they be our leverage points? Or we have a farm to library program. So how you're going to the library, it's great to get free, nutritious, local food, high quality there as well. So, there's all these lofty goals, and it's just leveraging the existing partnerships, I think, should be a continually goal, and that is our floor as we go towards this greater ceiling of a healthy community.
Excellent. And so, just trying to keep on top of keywords here. So we have tailoring, we have transitioning, right? Those transitions of care that are really, really crucial times for improved nutrition, because we know that many of those folks are at risk without, they don't feel good. They don't want to cook. They don't really have the capacity to get better food in. And then they're at risk for bouncing back into the healthcare system because of potentially some food choices when we think of folks with CHF or something along that line. So there's a huge opportunity to improve quality of recovery in that transition group, right? We also have the transportation challenges, and I think that those are ubiquitous. They are a challenge no matter where we are in our communities, and even carrying food and getting food home safely, things along that line. So transportation, another common denominator of how you all are operating to try to you really identify the gap that has to be closed to improve this access and improve these outcomes. Kathleen, would you please share a little bit about, you know, you kind of already shared one of your aha moments, right? If you were to say you had, you know, one piece of the puzzle that you would like more capacity for, what would it be?
Um, well, I know that when we left the hospital setting, actually in the current iteration of the program, we no longer, excuse me, make as a prerequisite that people have any chronic health conditions, although many of them do, of course. So I guess the idea of really focusing a lot of more of our efforts on prevention and
Awesome.
working with families with young children and getting the message out to mom, dad, whoever the caretakers are, that this is critically important at a very young age, sets the stage for the rest of their lives. You know, of course, at the end of the day, just like everyone else said, our end goal here is to be able to work with the people we work with long enough so that they're in a position where they have the skills, the knowledge, and um, the ability to access healthier food and to prepare healthier food for their families.
And really benefit from it.
Yeah, and really benefit from it. And it's, you know, we all know the statistics about how, you know, diabetes, overweight, obesity is an epidemic in this country, but we also all know that if you take the CDC maps that look at each of those issues and you overlay them with a map of poverty, you start to see patterns of where that's really happening the most in this country. So I think that while some people feel that it is just a matter of access, it is. It's also, I think, a matter of education and really, really tightly making that link between food and health. And
So I'm sorry. So I'm
right.
what I'm hearing you're all saying is what really would be the subject of our next question is that you're working on ensuring that there is you're building capacity through reducing food insecurity and improving nutrition security. Does that resonate? Hannah, would you mind speaking to that?
Yeah, absolutely. So, you know, and I know previously we had spoken about the difference and the really key difference between food insecurity and nutrition insecurity. You know, food insecurity is the lack of access to foods, and nutrition insecurity is the lack of access to fresh and healthy foods that are going to help prevent chronic illnesses and treat chronic illnesses and help us to live a happy and healthy life. So, that it's absolutely important that we address that, because if we are just addressing food insecurity, we're really failing to go that extra mile in being able to help people have a better quality of life. And it circles back. It's kind of like a domino effect, you know, if we can help people to prevent chronic illness and to treat their chronic illness with fresh and healthy foods, they're going to be going to the emergency room less, going to the hospital less. We're going to see a decrease in health costs and healthcare costs, and then this money can be put back into the community. So this kind of saving money in a way and actually putting money into the person is really helping us to put more money into each individual and each human, and actually recognizing their dignity as well. So, and this is not a blow to food pantries, and I think food pantries are very important in the system. We just have to be the ones to help to continue educate on what are maybe some better foods to include in the diet, or how to eat a more colorful diet. And, you know, we dietitians and everyone on this panel here, it's not about having a perfect diet. It's about just including, like Josh said, just an apple in the bag or an orange in the bag as well, or putting a little bit of lettuce in there. So that is my lengthy definition of nutrition security and how important it is, and how it really causes that domino effect of really being able to put more money into our communities where we really need it, I think.
Yeah, that is actually nutrition security, I think, is actually even a little bit broader because we know that even folks with resources, only 1 in 12 on average are getting anywhere near the produce intake that is recommended. And Kathleen, your comments about basically seeing patterns, those connections of poverty, those communities that have higher challenge, higher numbers of challenges and risks and things along that line. Again, it is a very circular situation. So it seems as though that we could eventually find an off ramp here. And I do believe that the food as medicine model is part of how we're going to keep driving, even if the data we're capturing is the reduction in hospitalization, is less about that individual's care, but more about that community health impact, then over time we'll be able to drive the data to keep expanding and funding these programs. Um,
And that's a key point, though. It is over time, and it seems
mhm,
like a lot of people who are maybe going to fund these programs want to see it quickly, and it's over time. We got in this position in this country in general over many, many years, and now it's supposed
mhm.
to be turned around by one program in 6 months or 1 year. Yeah,
True. I mean,
so it's hard.
it's a great point is that not only do we need to deepen the investment, we actually have to ensure that we give things enough time to be shown. It's been
Yeah.
one of the challenges of nutrition care all along, right? Is that people who
Mhm.
get nutrition care now may not really see benefits to that until a year out. And that has been very hard for healthcare to wrap its data and metrics standards around that these are interventions that are long term when we are trying to create more short term snapshots. It actually drives us to the question, are we suggesting that people should be replacing medication with food?
I can jump in there. I think even just to respond to what Kathy was saying about it taking time is, our minimum program is 6 months for a client to move through, and we even see clients re-up the program, and so you're looking at a year to even start to look at some of that, behavior change and that health outcome data, and so time is definitely slow, but you can take some of the comments that Hannah said, whereas like you're even just when our pantry coordinators are communicating with their clients on a weekly basis, it's the energy in their voice, it's the energy to engage, the energy to want to be involved or even be willing to try new foods, and those are all observations that we track and we take into
Mhm.
consideration.
Yeah.
um, but like you said, it is hard to go back to the funder and say, hey, look, this is equal to the
Right.
importance of health outcome.
Mhm.
But yeah, to kind of go back to what Ellie was saying is, I don't think any of us on this call are suggesting that medication should be replaced by food. I think what it goes to is, those numbers that I brought up earlier, that $160 to $160 billion to fund diabetes, but only 150 billion to fund the entire USDA. Like, we don't have the funds that equally match. And so there has to be more action towards a preventative nature so that we can use the money on our healthcare system and innovation and research that also takes a lot of funds. How do we redirect some of that money towards being preventative? And we know that from other successful models, whether it's a fruit and vegetable prescription model or a food as medicine model, like Josh said, that it does, access to fruit and vegetables do lower your A1C levels.
Mhm.
And that is in addition to the medications that you're taking and the program and nutrition education that you're following. But we know that it works. And so it should be in parallel too, and as a extra thing that can help achieve your goals at a lower cost, to be honest.
Yeah, agree. It's a huge opportunity, but we've got our finger in the dam with these programs right now, and we need to shift that into more preventive. And when I listen to you all describe how your participants change as they go through your programs, the word that keeps coming into my head and how I've always felt about nutrition education is confidence. If you get a diagnosis of a chronic disease, whatever store you go into becomes a pretty intimidating and stressful place, because if you don't have that working knowledge that can help you navigate that space, and then you always feel like you're on the wrong side of the equation when you are making food choices, whatever your access is. And that confidence and that skill building is so key to the prevention and management of our chronic diseases that are driving so much challenge into quality of life. So I think that confidence is such a key here. We are heading towards, we've got about 10 minutes. We do have a couple of questions up. And one of them is from Michael Foster, who asked, who provides the meals? And are they available throughout New York State? I wonder, Alex, if you could give a snapshot on that at all.
Yeah, that's a great question, Michael. Thank you for asking. It goes back to those 17 pantries and partners that we work with. And so 2 of those are making prepared meals. And they go off of a similar model that Meals on Wheels uses and the senior meal menu use. And those are provided by Altamont Feeding Program, which serves Albany, Schenectady, and Rensselaer County in the Capital Region. And then we use LifePath, formerly known as Senior Services of Albany County, who they also provide prepared meals for Albany County. The rest of our 4 counties are served by our actual food pantries. And so the food pantries coordinate with their clients. They do extensive intakes where they go over culturally appropriate food. They go over diet preferences. They go over, their health condition diet preferences. And then those meals are packed and then they're delivered either on a monthly or weekly basis. And that kind of gets back to for the monthly and weekly packages, bringing client choice into them, working on bringing dignity to the center of the conversation so that the client is comfortable with what they're receiving in their bag. They enjoy what's in their bag. They have choice to make those decisions, but they have choice from healthier options. So we do follow a strict guidelines when it comes to the contents of the bag. But it's served within the 4 counties, and they're served by our 17 pantries that work in our coalition.
So I think we can all speak to, the folks we have on the panel today are, snapshots from their own communities, but we know that there is a very functional, similar network that goes across the state. And again, they are all different models. They are all using all different resources, using all different types of funding, or not, and just really, all sorts of volunteer and, different community models. FoodLink out in Rochester now, developing things like cafes where they're training food service workers who might move into roles in programs like this. I think that we're in a very innovative time. So as far as, saying who's providing the meals across New York State, they are a wide spectrum of agencies and community-based organizations and nonprofits. And I'm not sure that you really could pigeonhole just one entity or type of entity, right? So another question is it helpful to track behavioral antecedents such as knowledge, attitudes, belief, and skills? Kathleen, would you mind?
Yeah, actually, we do track that. That's the one thing we have a lot of information on. We ask clients when we enroll them a few key questions that gets at, that get at the quality of their diet, And then we ask them again midpoint, and then if they're still with us at the end, we ask them a final time, and we have very good results. But and we do as well have access at some of our sites to the medical records and have tried to get some clinical data, but we're not, we're not screening for diabetes. We're not, so it's whatever's in the record. So that's the N for that is very small at this point and would not be considered statistically significant. But I think it is helpful to track that information to the question because if you can make the leap and say that the research shows us that this is the kind of diet, and I've been doing this for over 30 years and it's the same story all the time, it is the diet that helps prevent obesity, diabetes, hypertension, and so on and so forth. So if you can say that you have changed people's eating habits in that respect, then you could make the link that this is a surrogate marker for potential better health down the line.
Sure. So as we look ahead, I mean, for each of you, we're at the 5-minute mark here, maybe a little less. What are your hopes of where you'd like to see your program be in 5 years? There is definitely an advocacy, comment in the world that says we'd like to have none of these programs exist anymore because we don't need them, right? But I'm not sure we'll ever be out of that. Certainly not in the next couple of generations. But let's go in reverse here. Hannah, would you please share your thought on that?
Absolutely. I, of course, see being able to reach more people in the community, doing better community assessments to better understand what everybody needs on an individual and community basis. And this actually kind of goes back to the question of, did we want to replace medications with a healthy diet? Obviously, no. The goal, I think, of a food pharmacy would be able to have a very strong multidisciplinary team. And there's a lot of, and I've only been a dietitian for a few years and have worked in healthcare not very long. But I've seen in every case that having access and the brains and the knowledge, working with a dietitian and a nurse and a social worker and a doctor and, as many disciplines as we can, I think that's where the success really comes from, because that is well-rounded care for the client, for the patient. So hopefully in the future, more food pharmacies can be better funded to have that multidisciplinary team. And, like Kathy had mentioned, to just better be able to track that kind of clinical data, as much as we might have other kinds of success stories, personal stories, like you mentioned in the chat, attitudes, beliefs, skills, knowledge. We know sometimes that's not what funders are looking for. So if we could probably have better access to that data, and to be able to just offer more resources for the clients, we found that the more resources that they have, they know that they're more supported. So yeah.
Excellent. We're down to the pretty much the end of our time. I'd like to say thank you to everyone who has participated in the panel and our questions. We are, again, I think food is medicine, and where you all are working and all of the insights you're capturing will help us build stronger nutrition and care systems, more holistic, to what Hannah was just saying, correct? That really do connect our health from start to finish and give us that optimum quality of life that I think we're all trying to support. Anybody have a last comment they'd like to share?
Just sorry about the typing. Those were my earrings. Nobody was typing. Sorry. I took them off.
So now we've solved that mystery too. So thanks so much, Alex. Thank you all again for being part of our discussion today with Food is Medicine. And, look for these resources in your community, support them, learn more about them, and how you can participate in improving and creating a more healthful, food-centric and person-centric model. Thanks, everyone, for all the work you put into this. Thank you.
Thank you.
Thanks, everyone.
Thank you all.
Thank you.